Hello everyone and welcome to our first session of Intelligent Conversation about Clinical Microbiology. I'm your host, Dr. Frank Caligiuri, and here I have with me my colleague, Dr. Eric Wombwell.
It's a pleasure to be here.
And today we'd like to just have some intelligent conversation about clinical microbiology for all of you guys to listen into. The purpose of this is that microbiology has been reviewed in the coursework previously. Those of you that UMKC on the Kansas City campus would have taken microbiology under the heading of UMKC. However, at the satellite campus in Columbia, that would have been done under the auspices of the University of Missouri. However, regardless of where you took microbiology, last fall, you all received a lecture that we worked with Dr. Phillips to prepare on the pathophysiology, which included a review of the microbiology and some of the major reasons that people acquire infections. Today, we're going to take a twist on this and do a little bit more in-depth talk about the microbiology in a clinical context, what we see on an everyday basis, and that way we'll have more time in pharmacotherapy to discuss the drugs. Anything you would like to add, Dr. Wombwell?
I'm just excited to be joining you to have actual intellectual conversations about microbiology from a clinical standpoint. And I hope you all can gain a lot of information from this.
Yeah, this should be fun, and hopefully some of these things will allow this information to stick for you guys, and you can review this on the Blackboard website at all times. Thank you. Well, we'll use this slide to get us started here for some intelligent conversation. What we have here is all these microbes, or things that are pretty small out there in the world, and see how they are in comparison to us as mammals, as life forms. On the far end of the spectrum, you have viruses that are least like us, and it moves all the way to parasites that are most like us. One of the things that's not on here is something known as prions, which are actually aberrant proteins that are known to cause mad cow disease. What do you think about mad cow disease, Dr. Wombwell?
Mad cow disease? Gee, it was like it was here and then it was gone. If you had a choice between being the leading scientist in your field or having mad cow disease, which would you choose?
Well, of course I'd choose being the leading scientist in my field.
Good. I was worried you'd say mad cow disease.
No, definitely not me. And in fact, that's all we'll be talking about, mad cow, for the rest of this intelligent conversation.
Sorry, I had to.
We're going to focus on the bacteria for this rest of this conversation. And these are generally pathogenic bacteria, as we'll discuss normal flora that usually do not cause infections. Infectious pathologies can either be communicated or transmissible, and therefore a lot of times there will be contact precautions with parts of bodily fluids, contaminated objects, or airborne inhalation of things. There can also be spread via vectors, and if you're interested in vectors, what would you suggest, Dr. Wombwell?
I'd really highly suggest enrolling in our zoonotic illnesses course. It's an elective that we have offered in the spring. It's on Wednesdays from 4 to 5 p.m. where we talk about vectors. We talk about mad cow disease. We talk a lot about these zebra illnesses that you may or may not cross paths with in the future, but that we'd highly recommend you signing up for that course.
All right, well, thanks for the nice plug for our course. I think that's well suited for this talk. And we're going to move on to the next section. Again, we're going to focus on the bacteria, or the bugs. So here's a general outline of the bugs. You know, in this conversation, we're going to talk about normal flora, the pros and cons of it, Gram-Stain review, what that means, and that's our general classification of pathogens. And so they'll end up in one of these 4 categories. And these are the 4 main categories we would like you guys to focus on, which is gram-positive bacteria, gram-negative bacteria, atypical bacteria, and anaerobic bacteria. We're really not going to be discussing in our 3 weeks Mycobacterium, which is specific for tuberculosis infections. Dr. Wombwell, why is it that these atypical are called as such?
It's basically because we are unable to stain them like we are with a gram-positive or a gram-negative stain. These bacteria don't have a cell wall that takes in the dyes, and so we're unable to detect them when we do a gram stain. In addition, we usually see these type of organisms in pneumonias, and they're typically less pathogenic than a typical pneumonia, and so they can be walking pneumonias where they go 1 or 2 weeks without having severe signs, and so it's more of an atypical presentation. And usually the way that we can detect them is through an antigen test, whether it's a urine antigen test or a blood antigen test, and so that's how they're a little bit quote-unquote atypical.
Huh, interesting. And these gram-positive, I should probably know what that means. It has nothing to do with weight, right? It has nothing to do with the weight of these
right.
organisms.
So, Dr. Caligiuri, why do we have this classification of gram-positive and gram-negative? What's the thought behind it?
Well, in fact, it has nothing to do with how much these bacteria weigh, because they weigh less than even 1 gram.
Sure.
Yeah. So, but they're in fact named after the scientist Hans Christian Graham, who developed this procedure in the late 1800s that was done with the dye to show which bacteria would adhere to the staining as well, as you discussed. And so we classify them as gram-positive if they keep on the most dye, they withhold it the most and stay that dark, deep purple color. We call them gram-negative if that first dye is easily washed off, meaning it doesn't have that big peptidoglycan layer. It'll be easy to show you on some of these other slides, but again, it has to do with just the naming technique, and a lot of things in medicine are named after the smart people that come up with them. Maybe someday we'll have a Staph Caligiuri or an E. Wombwell out there. What do you think?
I find that highly unlikely, but I appreciate your insights into the gram-positive versus gram-negative.
All right, well, it's worth a try. So our normal flora is really important for us, and it's necessary for life. You know, it can work 3 different ways. You can have these parasites, symbiosis, or commensal organisms. You know, if we were both microbes, which one do you think we would be?
I would definitely have to say symbiotic.
Symbiotic relationship. All right, well, so I would agree with that statement, because these are things where people both benefit from the relationship. And so we make a good team, I think. So we're definitely not the parasites who one person will drive down the life of the other person, or commensals where that organism might live within a host but have no effect on them. We much more have a symbiotic relationship where we can benefit each other. And, you know, these normal flora are everywhere. Anything that's generally exposed to the outside, like your skin or your upper respiratory tract or parts of your GI tract, which are just inhabited by microbes as part of the nature of the gut. And in fact, it's kind of exposed through the open oral cavities, so you can kind of think about it the same ways. But in fact, just in the gut alone, there's 1,000 different species of microbes that are all normal flora. And what normal flora we all carry will depend on a lot of different things, as you can see here, like gender and stress. But what is the concern with some of these sterile sites? Why are these sterile, and how do they play a role in infectious disease?
When we think about sterile sites, we're usually thinking about blood, CSF, those sites in which bacteria do not normally live. So anytime that we would culture out a sterile site, such as the blood, such as the CSF, and we find a bacteria, that is an abnormal finding versus skin infections or oral infections, where we do a culture of those sites. We would expect to see pathogens there, but we use specific mediums, culture mediums, that isolate out for what we'd expect to see in those areas. And so then once something does pop up, that is more of an indicator of true infection.
Gotcha. So basically, if we find bacteria in any of these sterile sites, it's more than likely an infectious process.
Certainly.
Yeah. So this is some of the normal flora that we encounter, and there's one of these I really want to highlight in particular, and this is especially Staphylococcus epidermidis. Its name epidermidis implies that it lives on your skin, and in fact, it's the most abundant bacteria that is encountered in the microbiology labs, because oftentimes through blood draws, it shows up in blood cultures as a contaminant, and it paints a pretty different picture for those that are just looking at microbiology reports without the clinical picture of the patient. And that's why it's always important to look at the patient along with the data that you get from their cultures and sensitivities. So the way this Staphylococcus epidermidis works is that it can be an infection in a couple cases that you'll hear about in class. Those are bacteremias that are started by a catheter-related bacteremias, or they're from endocarditis. However, Staphylococcus epidermidis, by its nature of living on the skin, is never a pathogen in skin and soft tissue infections, so that should never be confused. Clinically, the way we use this is we determine how many of these blood cultures have Staphylococcus epidermidis. Generally, if only 1 out of 2 end up with Staphylococcus epidermidis, and it definitely does not match the clinical picture, more than likely that's just a contaminant, and that was just acquired through phlebotomy technique that didn't quite clean the area or picked up some Staphylococcus off your skin, and I generally don't worry about it.
No, that's a good point, Dr. Caligiuri. The other thing to consider is this 1 out of 2. So what does that mean? Generally, when we're drawing blood cultures, we're drawing from 2 different sites. So one from a peripheral line and one from a central line, if they have a pre-existing central line, or potentially just one from a left peripheral line and one from a right peripheral line, so we have 2 different sites to look at. And what's kind of interesting is if we do draw from a peripheral line and a central line, generally that central line culture is going to come back quicker than the peripheral line, and so that would be an indicator of a central line infection versus a contaminant.
Yeah, that's an interesting point. Also, if you're never unsure, you can always repeat blood cultures, and perhaps having 4 blood cultures or tubes full of blood might give you a better picture. For example, your 1 out of 2, if it becomes 1 out of 4, without a doubt you're dealing with a contaminant, and if you end up with 3 out of 4, maybe you need to reevaluate things and see if the patient is at risk for a pure staph epi infection. But again, keep in mind that this is more than likely a contaminant and most times encountered. This one's interesting because it kind of has another name. What is the other name that we sometimes refer to it?
Coag-negative staph.
Okay, so that's a big distinguishing factor from our most pathogenic Staph aureus, what I would say is one of our most feared bacteria, Staphylococcus aureus, which is coagulase positive. So you might report this as staph epi, or your lab might just tell you coagulase negative staph, which is essentially them telling you staph epi as well.
Correct.
As far as these other normal flora to talk about, you'll see that they are also pathogenic in some cases, and it really just depends on whether they get out of the environment that they're suited for. So, for example, Haemophilus is a normal flora inhabitant of your upper respiratory tract. However, if this makes it into the blood-brain barrier, it can cause meningitis, and we definitely don't want that because that CSF fluid is one of our sterile sites. So that's sort of how I think about other normal flora. Would you add anything else?
And sometimes we can have colonization of bacteria that we would consider to be pathogenic, like the Haemophilus, like the Strep pneumoniae. But again, what we've tried to do is look at gram stains as well. So if on the gram stain we see high levels of epithelial cells and low levels of white blood cells, then that would tell us it's probably more of a contaminant versus a good culture. So those are other things to look at on the gram stain as well.
Great points. And in closing, just remember that you're not just treating cultures, sensitivities, you're treating patients with active infections. And if you think somebody has a pneumonia and they don't have a cough and no problem breathing, then maybe it's just leading you down the wrong track. So here's a nice picture of the gram stain, and I think this really paints a better picture of why they stain the way they do. If you look at this gram-positive bacteria, and we'll talk about which ones those are later down the road, they have this huge peptidoglycan layer. And it is because of this peptidoglycan layer that they're able to withhold all of that dye and stain purple. This peptidoglycan layer cell wall will also be a site that we use antibiotics to kill, most namely the beta-lactam antibiotics, which you guys should all know which 3 classes that includes. Can you remind them what 3 classes are included in beta-lactams?
Sure. 1 would be your penicillins, 2 would be your cephalosporins, and 3 would be your carbapenems.
Yeah, it's extremely important to remember that. And that's in contrast to these gram-negatives, who their peptidoglycan layer is again shielded by a secondary plasma membrane. And with this plasma membrane, I sort of like to think of it as it makes it a little slippery. And now this dye is not going to stick. So that first purple dye washes off, and it's only until they do the counter stain with the pink dye that that'll stain, and we'll turn those gram-negative bacteria.
So what do we have in terms of common pathogens for our different stained organisms? Generally, when we think gram-positive, we're thinking Staphylococci, Streptococci, Enterococci, and maybe even to a lesser degree, Listeria. We're primarily thinking Staphylococci, Streptococci for cellulitis, and Enterococci is coming up more if it's something of a gut in nature or a urinary in nature would be a gram-positive that we think of. What about gram-negatives, Dr. Caligiuri?
Well, gram-negatives are the exception. You know, these gram-positives are very few actually pathogenic gram-positives, and so what I like to say is if it ends in cocci, that's because of their structure. They're being circular and spherical in nature, but that's a good reminder that generally they're gram-positives. Listeria is the outlier there, and will only come up in meningitis discussion for the next few weeks. But so then I used to think, if it's not one of the cocci, it's probably a gram-negative bacteria. And there are much more pathogenic gram-negative bacteria, and oftentimes they have pretty bad resistance patterns as well. One thing to keep you straight on things like Enterobacter versus Enterococci is that all the cocci are positive, and all the bacters that you might encounter, whether it be Acinetobacter, Citrobacter, or Enterobacter, are all considered gram-negative pathogens. So the hallmark of the gram-negatives is really in the gut. It's E. coli. This is what everything is centered around, is the E. coli for urinary tract infections, diverticulitis, abdominal infections, peritonitis, either primary or secondary. And then the other big gram-negative player that comes out a lot is Pseudomonas. We talk a lot about Pseudomonas because it's a very multi-drug resistant bacteria that needs to have adequate coverage, and there are very few antibiotics that have inherent coverage for Pseudomonas. So we often dictate therapy based on pseudomonal coverage or not anti-pseudomonal coverage. And what I also like to add to that is think about it this way. if Pseudomonas is the most resistant of the gram-negative, generally most drugs that cover Pseudomonas will cover all of these other gram-negatives on the list. Of course, there'll be exceptions to that, but it just makes sense that if Pseudomonas is the most resistant and I have a drug that's active against that, then it surely should kill my H. influenza or my Moraxella, which harbor less resistance.
Going back to our kind of our gram staining and culturing, one of the things that can be an indicator that you may have Pseudomonas is whether or not it's enteric or non-enteric, meaning when they put it on the culture plate, it's either fermented or unfermented. So if you get back an initial gram stain or an initial culture that says non-enteric gram-negative rods, then our suspicion for Pseudomonas, for Acinetobacter, for the mean gram-negatives starts to increase, and we may want to expand therapy in those cases.
That's a great point, and I'll talk about some other clues in the urinary tract infection that we can use to tell if it's Pseudomonas or Enterococcus by the same fermentation thing, and so we'll touch more on that so it can stick a little bit better. These anaerobes, there's only a couple of them, and on the whole, we kind of talk about them very generically. We always say, oh, we need anaerobic coverage, or anaerobe this, or anaerobe that, and what I want to say is we really are talking about Bacteroides 99% of the time. We're looking to cover Bacteroides, which is our pathogenic anaerobe that lives in the abdominal or in the gut, so to speak. Clostridia has a much smaller role, and the two times I think about Clostridia are very few and far between. The most common is C. difficile infections, Clostridium difficile, which causes diarrhea, which we'll talk about in class. And then the next one, which is much rarer, is Clostridium perfringens that causes gangrene or necrotic tissues, or what we call flesh-eating bacteria. So anaerobes are smaller players, but they need different bacteria. They're different bacteria, so therefore often require different agents or additional parts such as beta-lactamase inhibitors to extend coverage of these anaerobes. And Clostridia itself, or C. diff, is kind of tricky. We only have 3 or 4 drugs that will kill it entirely.
Yeah, and I don't really have anything else to add to anaerobes. Just kind of finishing up on this slide is our atypicals that we kind of touched on briefly earlier. Again, Chlamydia, Mycoplasma, and Legionella. These are typically associated with pneumonias, and kind of an interesting story on Legionella. It gets its name from a convention that was occurring at a hotel. It was a Legion convention, and a bunch of people came down with pneumonia, found out that Legionella, or this microorganism, was in the contaminated water that they were all drinking, the tap water, and so its name comes from that. But again, these are organisms that more walking pneumonia, less severe, and we treat them with a subset of antibiotics.
That's a great, interesting historical perspective, and I often think it's important to know the historical perspective of some of these things, and will help you identify their place in this world and as pathogens. Staphylococcus is here in vast amounts on this slide. You can see all these little tiny colonies of Staphylococcus here in purple, and you can see how they're all arranged in these little grape-like clusters. And in fact, that's what the prefix staphylo means. Again, coccus means its spherical shape. This is the only bacteria that presents in this fashion, of gram-positive cocci in clusters. When you get that on a microbiology report, you should only have one question from that point forward. Are we dealing with Staph aureus, or if I'm dealing with Staph epidermidis? But without a doubt, you're dealing with Staphylococcus. You're not dealing with Streptococci, Enterococci, or certainly not any gram-negatives, as it's stained with the gram-positive purple. And, for me, this is probably one of the most feared bacteria, personally. I would rather end up with a whole lot of other infections than a Staphylococcus infection. So how about you?
I don't know.
I'll say something like this, too. Here's another slide that's up close, electron microscope, and again, you can see how these are arranged in their clusters. So again, clusters is Staphylococcus always, and every time that you encounter it.
Yeah, and this is why a lot of times when you get an initial culture, gram stain culture back, it may say Staphylococcus that appears to be Staph aureus, or gram-positive cocci that appears to be Staphylococcus, is because what they've seen are these clusters. It may not read out as gram-positive cocci in clusters. It may just read out gram-positive cocci concerning for Staphylococcus or something along those lines.
And so here's some of the specifics on Staphylococcus, and I got this nice little picture here as reminders for you. But it's an aerobic bacteria, and so it needs oxygen to survive. And it's always in clusters, as we've talked about. It's highly virulent and highly resistant, and you guys are all very familiar with what we call MRSA. So how do we classify this bacteria clinically, and how will you need to classify it for the exam? Well, first it's divided into coagulase positive or coagulase negative, as we've previously discussed. Again, coagulase positive points towards Staphylococcus aureus, the more pathogenic strain. The lab will report that out to you. That is not a determination you will make. However, you must understand if they report out a coagulase negative Staphylococcus, what that means in English, which is basically that it's Staph epidermidis. These genus and species will make up the last two letters of the nomenclature that we use to identify these bacteria. The first two letters of that nomenclature refers to its sensitivity to the antibiotic methicillin, which was designed specifically to kill this bacteria. This antibiotic was created for no other reason than to fight Staph aureus. And unfortunately, over time, it's developed resistance to even this, to the methicillin. Now, methicillin is interesting because we don't even use it anymore, do we?
No, what we typically use now is an oxacillin, a nafcillin. The oxacillin is what typically shows up on our culture and sensitivity reports, and so if you see that it is resistant to oxacillin or sensitive to oxacillin, that is interpreted as your methicillin. And then we don't use either of those agents for actual treatment. What we would then use for treatment is nafcillin. So this is typically a hard area for everyone to keep straight, but please refer back and remember that it's methicillin, which equals oxacillin, which equals nafcillin.
Yeah, and just to clean it up and make it a little easier for you guys, none of these are susceptible to good old penicillin. So basically, when you're dealing with Staph aureus, it starts here with the methicillin, and it's either sensitive to that class or it's not. And if it's not, we're dealing with what we call MRSE or MRSA. A good clinical pearl for you guys to know is this. If somebody has a blood culture that pops up with 2 out of 2, for example, gram-positive cocci in clusters, and you're concerned for an actual bacteremia or infection at this site, you must start vancomycin empirically. And the reason for that is about half of Staph aureus is resistant to methicillin. So therefore, empirically, it's important that we get the appropriate antibiotics and we can de-escalate once we know the sensitivities. And we'll talk more about de-escalation in class. A couple other things that are really important about Staphylococcus is its reason for such bad resistance. One is it's been producing beta-lactamase against penicillins, and this is the first mechanism. You know what I like to say? Is that we haven't had a penicillin able to kill Staphylococcus since World War II. It just doesn't happen anymore. You will never find anything that is susceptible to penicillin, and that's because of this beta-lactamase. However, you can use drugs that are active against beta-lactamases. So either those are the drugs we just discussed that were developed just for this reason, like methicillin, oxacillin, and dicloxacillin, and nafcillin, or the first-generation cephalosporins, which are also specifically created for MRSA. Cefazolin is our mainstay of that. And as far as the inhibitors go, we'll learn about that in class, but basically that's why augmentin will have activity against MSSA, but amoxicillin alone will not have activity because of this beta-lactamase production. I guess I can't stress that enough. Do you think knowing which bacteria produce beta-lactamases and how to overcome them is an important principle?
Yeah, and I think one of the common confusions here is when we're talking about staph versus strep, which we'll talk about strep here in just a moment, but when we think about staph, the resistance pattern is the beta-lactamase. When we talk about strep, its resistance pattern is the inability for penicillin to bind to its proteins. And so when we talk about staph, the concern is for beta-lactamases, and so we need to use anti-beta-lactamase penicillins, nafcillin, dicloxacillin, or our cephalosporins, which generally have good inhibition of the beta-lactamase. So as you said, Keflex, cefazolin are all good there.
Yeah, that's interesting that you bring up these site of the PBPs, which is the site of action for all these beta-lactam drugs. And this is why MRSA scares me, or staph scares me as well, is because it has that as well as a secondary mechanism. Now, again, it's not as common as it is in the Streptococcus species because that's all it can do for its resistance. But this alteration of the PBPs is what ultimately leads to MRSA. And that's why no matter how many times you throw beta-lactamase inhibitors at it, it doesn't matter at this point because now it's changed where those drugs totally bind and has put us into a new realm of drugs like vanco and daptomycin altogether. So again, because it has multiple resistance mechanisms, Staphylococcus aureus is a pretty bad bug out there. This community-acquired MRSA is what you'll talk about in a couple weeks, huh? And it does have some less resistance, right?
Yeah, so typically we have more antibiotics that are active against community-acquired MRSA. Its genotype is the USA 300 versus the USA 100, which is more specific to hospital-acquired MRSA. One of the main things to think about in terms of the pathogenicity, or how virulent or how bad the infections end up being between hospital-acquired and community-acquired, is you may say to yourself, well, if it's community-acquired, it's probably less virulent, or it produces less severe infection. But it's actually the opposite. The community-acquired MRSA more frequently encodes for a toxin that causes worse infections, versus the hospital-acquired MRSA typically does not encode for this toxin, and typically is a less severe type of infection, although their resistance patterns are opposite. So it can be an area of confusion. But remember, community-acquired, we have more agents active against it, but it's a more severe. Hospital-acquired, less active agents, but typically less severe.
I think this is a good time to talk about just one other definition, is virulence versus resistance, and are they synonymous? And absolutely they are not synonymous. You can have a drug that is very not virulent at all, meaning that even if you get it in your bloodstream, will have very little effects on you. Now, a good example of that is staph epidermidis. In the event you got a staph epidermidis infection from, for example, a IV line that was placed or a catheter, that is possible. However, those people will have very low-grade fevers. Very rarely will they ever end up in sepsis or in shock or low blood pressures, and they'll be easy in that aspect to manage because of the low virulence. However, the flip side of that is staph epidermidis is highly resistant and will need vancomycin for that treatment. So just because a bug is resistant doesn't mean it's more virulent, and just because a bug is virulent does not mean that they're resistant. You have to evaluate each of those factors individually for each bacteria. Staphylococcus aureus, again, it's everywhere and can cause every infection. So some of our most serious invasive infections, like skin and soft tissue infections, osteomyelitis, an infection of the bone, bacterias, endocarditis, pneumonias, the entire gamut of infections can be caused by Staphylococcus aureus, which really speaks to the nature of it. Where some other bugs, for example, what infections do C. difficile cause?
Typically, we just consider it to be a pathogen of the gut, so causing severe diarrhea, the C. difficile infectious diarrhea.
So this is important to note about Staph aureus, that you can encounter it in multiple sites, and that's why you'll see a lot of vancomycin used empirically, because if you don't know where the infection's coming from, there's still a likelihood that Staph aureus can be involved in that. Again, methicillin-sensitive Staph aureus, these are the drugs of choice, nafcillin and cefazolin, the first generation, and MRSA is the gold standard. And I really think this is time for some intelligent conversation about what it means to have a minimum inhibitory concentration equal to 2 for MRSA, for vancomycin, and treating that. Is that something to be concerned about, even though a 2 is considered susceptible?
So there's different situations in which we're going to be concerned, and this is why we want to have an intelligent conversation about this. So the one thing to keep in mind is always looking at your patient. All right, so the first thing we're assessing is whether or not the patient is clinically improving or not. By the time our cultures and sensitivities come back, by the time we see this MIC, generally we've had 48 hours to 72 hours to watch this patient either 1, get worse, 2, stay the same, or 3, improve. And generally, if they're improving, this MIC of 2 really doesn't tell us a whole lot. It's more that at its basis, the 2 tells us it's going to be very hard for us to achieve adequate concentrations in the body to provide that bactericidal effect with vancomycin. However, if our patient is improving and they have this MIC of 2, it tells us that in this patient, the pharmacokinetics, the pharmacodynamics are such that we are having clinical improvement, we are having that bactericidal effect with the use of vancomycin. However, if we get this MIC back that says 2 and our patient isn't really improving or worsening, this is definitely a case in which we would want to change to an alternative therapy to treat a patient with MRSA and an MIC of 2. So potentially daptomycin if we're looking at bacteremia or a skin infection, or if we're looking at a pneumonia, we would be considering Zyvox at that point.
Yeah, I think that's really important to know. The clinical aspects and clinical care of your patients will trump anything that appears on any reports or any laboratory findings. And so I think that's a very valid point. This really makes a big deal if your patient is worsening and makes you pretty confident about changing to some of these newer, expensive, fancier drugs. However, if they are reported at an MICF2 and doing well, it's really not worth the extra change of antibiotics if they're clinically improving. And I think that's the most important thing to take away. And then Staph epi, we've talked about quite a bit at this point. Here's some details for you all to look over. And I really like how the CDC sums this up, as they say, never treat a single positive blood culture. And of course, as we've discussed, you need 2 out of 2 to be considered a causative pathogen. And as you know, it's everywhere, so encountering it is not uncommon in the hospital. Do you see this on micro reports?
I see Staph epi all the time. Sometimes I wonder to myself, do we have a new phlebotomist in that's drawing cultures? Because seriously, we'll go in little spurts where all of a sudden we see a bunch of these 1 out of 2 gram coag negative staphs, and you say to yourself, what's going on? So it does pop up more frequently than infrequently, and again, it goes back to what's the clinical picture of the patient, and are we 1 out of 2 or are we 2 out of 2? Really assessing the patient to determine whether or not we need to consider this infectious or not.
Yeah, one of these cool things about staph epidermidis is its association with foreign bodies, and why if people have prosthetic valves in their heart, they can get some endocarditis due to staph epidermidis. This is a really cool thing that has to do with its biofilm production, and staph epi will adhere to these foreign bodies and kind of make this slime over it that'll make it tough to eradicate. And every once in a while, we might require extra drugs just to help break up that slime and get him to not adhere, and that is rifampin that we use for that feature. And that's why when you hear some of these other things presented in later weeks, you'll see where rifampin comes into play in instances where there might be a foreign body, such as a prosthetic valve or even a prosthetic knee or hip that's been infected.
Wow, that's fantastic, Dr. Caligiuri. Thank you for sharing that
I love
with us.
fun facts.
It is a good fact.
And then the low virulence we've already talked about. Again, when if you have staph epidermidis infection, you're going to survive. Yeah, so you'll live. But this is the weird thing about it is, kind of I think of it this way. It's exposed to so many antibiotics living on your skin that it's just resistant. But unfortunately, that doesn't really matter too much since it's not a clinical pathogen a lot of times. But if you do ever encounter staph epi as an infection, you can bet your bottom you'll be treating it with vancomycin.
That's true. It is most commonly a methicillin-resistant pathogen.
So this is group A Streptococcus. It's still gram-positive, and it's still a cocci. What's different about this one is it usually appears in these long chains. I like to think of it like strip and strep. They come together, and so this usually appears as a strip of cocci. So group A strep is also known as strep pyogenes. These are synonymous, and you should be able to use these interchangeably as a clinical pharmacist. This again is an aerobic gram-positive cocci. The difference is simply it's in chains. We also call it beta hemolytic strep, and there are other beta hemolytic streps. So as far as what this causes, it's very limited to just a couple infections. So you'll hear about group A strep from only Dr. Wombwell because it only appears in some of the infections he's going to discuss. Mainly pharyngitis and cellulitis will be the only 2 times that you encounter group A strep. However, they are very common causes of that, are they not?
Yeah, typically these are about 50% of the cellulitis that we'll see is due to a group A strep. In contrast, pharyngitis, if it's bacterial in nature, typically it's always a strep that is the causative agent. So with pharyngitis, only about 2 to 10% are bacterial, but if it is bacterial, it's nearly 100% of the time. Streptococcus pyogenes and cellulitis about 50% of the time.
Yeah, this thing about resistance is interesting too, because even our good old penicillin from the 1940s is still active against group A strep. That leads me to pose the question, Dr. Wombwell, do you think that group A strep produces beta-lactamase?
Well, it's primarily because it doesn't have this beta-lactamase concern that we have with Staph aureus and Staph epidermidis. So that is a nice thing about the strep, is that we know we can still reliably use penicillins and not have to worry about that resistance pattern anytime we see a strep. a simple penicillin can take care of that.
Yeah, so essentially we should be using very narrow spectrum, cheap, old school antibiotics to kill group A strep. There's no reason we need to pull out any of the big guns for this one, huh?
Correct.
And Enterococcus is an interesting bug as well because on a gram stain, I'm not really sure if it's Streptococcus or Enterococcus because they look so much alike. You know, I guess the only clues out there is where did that source come from? So for example, Enterococcus is a big player in urinary tract infections, and Streptococcus is not a big player in urinary tract infections. So, you know, if I'm working and I have a urine culture that comes back with gram-positive cocci in chains, it's probably Enterococcus and not Streptococcus. And that's a really good way of how you can use this clinical microbiology to have intelligent conversations with your team members.
No, absolutely. I think that's a fantastic point. Is very often some of our urine cultures will come back gram-positive cocci concerning for Streptococci. And I think that's a very interesting note to make to the physician while you're on rounds or just in passing is this is likely not Streptococci. It's likely misinterpreted for Enterococci, and so we need to direct our therapy at Enterococci versus the Streptococci.
Absolutely. So always consider the source and consider what bugs or pathogens in that source. Again, Staph epi does not cause skin and soft tissue infections, so I'm not worried about it. And Streptococcus does not cause urinary tract infections, so that's usually not the gram-positive. Here's a nice electron microscope of Enterococci in chains. And what's interesting about Enterococci is it has a relatively low virulence, but is highly resistant. In fact, there's really only, I'd say, a handful of antibiotics that it's susceptible to. What do you think?
Yeah, I've got just 3 or 4 on my radar. Some of them used more often than others. What would you say typically if you have something come back as Enterococci right off the bat before you get susceptibilities back that you are using empirically?
Well, for empiric treatment of enterococcal infections, because it does have high resistance, vancomycin is the way to go because it's our biggest, broadest for gram-positives, one of which Enterococcus is. However, vancomycin is not the drug of choice for Enterococcus. Once we have susceptibilities back, if we know that it's susceptible to ampicillin, our aminopenicillin class of antibiotics, that is always the drug of choice to go with. And so you only have really a handful that'll be susceptible to Enterococcus at all times, and that's why it's really important that when you see it in a culture, you are aware that it's Enterococcus because potentially your empiric therapy was not covering this bug. Again, I think the best example is urinary tract infections because they're generally covered by or caused by gram-negative bacteria, so most of our empiric therapies may or may not include coverage of Enterococcus. But at the point we see that it's gram-positive cocci in the urine, we need to evaluate our empiric regimen and perhaps switch or add to it to cover this Enterococcus. You know, and here's the example, just one mechanism is how it overcomes Bactrim, which works on folate. It takes out the folate from your body to overcome that. As far as beta-lactamase production, it does that as well.
In general, some of the other antibiotics that we do think of in terms of coverage for Enterococci are nitrofurantoin. One of the things we get concerned about there is just assessing the patient's age, their renal function, because we've got some contraindications that may play a role there, especially in our elderly patients with reduced renal function. Kind of an interesting product is phosphomycin, which we can use in one-time dosing. That's a powder. It's just kind of a fun little fun fact to have in your back pocket to talk about phosphomycin, so I encourage you to look at it. And then everything else is if we've got really mean resistant Enterococcus, such as the Faecium and Faecalis. And so would you want to speak on those two?
Yeah,
two bugs?
for a long time I used to get these confused and just wonder which one is the big resistant one that I have to worry about. And so, you know, I try to develop mnemonic devices to help remind me of this one. I don't know if this is one of the best I've come up with, but it certainly has stuck. So what is important to know is we are concerned about VRE, or vanco-resistant Enterococcus, and when you look at what species makes up the majority of that, it's the Enterococcus faecium. Fortunately, 80% of the infections that you encounter by Enterococcus are due to Enterococcus faecalis. And then when you do encounter it, most likely it's UTIs, and as Dr. Wombwell alluded to, there's more treatment options in the UTIs because we can have high concentrations in the bladder. When we start to encounter Enterococcus into the blood or in dealing with endocarditis, our options are few and far between. Literally, guys, there's about 3 or 4 drugs we can use to treat this in the bloodstream. So kind of to summarize these Group A strep Staphylococcus and Enterococci, these are all the gram-positives. I generally like to think of these together. Their drugs of choice are always cell wall antibiotics, so it's either beta-lactam or if resistance dictates vancomycin. So, you know, if you're just thinking about quinolones or you're thinking about Bactrim, always think about these other drugs first. This is where you should start and move into the other drugs. Entero is a slightly different one because the other ones are going to be involved in some skin infections where Enterococcus is not. Its entero implies it lives in the gut and is slightly different. Again, don't get this confused with Enterobacter, which is gram-negative. These three bugs, Staph, Strep, and Enterococcus, will all pop up together next week when we talk about endocarditis, as they are pathogens in that. Not necessarily group A strep, but a different species of strep. Again, all gram-positives and will all be treated with beta-lactam or cell wall active antibiotics.